Thank you very much for the kind introduction. On hindsight, I might have chosen slightly wrong title. I should have changed it to crowdsourcing full stop for multi-center research and not just limited to specialist trainees, because I can see that there are quite a lot of multi-professional colleagues here in the audience. So I work at the Royal College of Anaesthetists, which is a very centralized organization within the UK anesthesia and intensive care structure. And we managed to get quite a lot of involvement in the studies that we carry out of our institution all across the UK, and hopefully this might be a model that provokes some kind of discussion as to whether or not it's applicable in the Asian and Australia and New Zealand context. So, declarations of interest. I am a specialist trainee, so I'm probably the most junior person on this panel, so take what I say with a pinch of salt. However, I did spend a bit of my time doing research the last couple of years, and this is a personal perspective from my point of view. Just going to cover these things in my talk. Probably not going to focus so much on why research is important. I think if you're in this room, you're already convinced, and a lot of the previous speakers have raised excellent points as to why we should be doing research. And then we're going to raise a few case examples of situations in the UK where we managed to get quite a lot of local front-line service providers to get interested in research and participate. And talk about the infrastructure that's arisen and ecosystem within the UK to try and facilitate these things. So why we do research on the broad aspect is to enhance patient care. On a more micro level, it might be, as an individual, we want to find out why what we're doing works in the context that we're delivering our care in. And also, there's good evidence that research-active hospitals have better outcomes, and therefore, it might be a bit of a Hawthorne effect. Therefore, if you participate in research in your institution, and if your institution is active in research, there is an association with better outcomes in your hospital. So participating in research may indirectly lead to better clinical care, even if your findings don't result in any change of practice. I put this slide up with probably the oldest reference that you'll see in this conference, a reference from 1948. So it's the 70th anniversary this year of the very first published randomized controlled trial in the BMJ. This was streptomycin for treating pulmonary TB. The reason why I bring this up is for a few points. Unfortunately, the laser pointer doesn't work, and you might have to focus your eyes a bit. So first of all, this is a randomized controlled trial in an era where people were doing a lot of case series and a lot of case studies, individual case reports. Second of all, this is a multi-center study in an era where people were giving their local context within a single institution. 6 hospitals were involved. Not all of them were teaching hospitals. The only teaching hospital, 2 teaching hospitals on that list are the Brompton and Harefield. So 4 out of 6 of these hospitals were what we call in the UK district general hospitals. Your run-of-the-mill, the equivalent to maybe Changi General Hospital here in Singapore, where the sort of data, the sort of patients you see might be more applicable to your local context in the person who's reading the journal article. And hence, the relevance of the data being acquired becomes more pertinent and creates a greater impact on the reader. The third point I want to raise is, it's very tiny, you probably can't read it. The Brompton Hospital, the study was led by Dr. J.W. Crofton, the streptomycin registrar. So this isn't a consultant, this isn't an attending physician, this is a trainee who led the study under the guidance of a consultant, obviously, in that institution. Just goes to show that junior colleagues can contribute towards research in a very productive way. But unfortunately, even despite this coming out in 1948, it took a long time for randomized controlled trials in multi-center studies to take off in the medical literature. There was at least until the 70s or 80s before we started getting really, really good multi-center trials for blockbuster drugs. And why is that? Research is expensive to conduct. It takes a lot of time, a lot of effort, a lot of people. It takes a lot of coordinating. And when you disseminate findings in print, the uptake of new practice is slow. And when the uptake is slow, there is a bit of a disincentive for you to conduct these trials. Why would I want to invest all this time if nobody's going to change their practice despite what I'm doing? There's also maybe a bit of a disconnect between the ivory tower university institutions and frontline clinical services. And I would argue that the more we involve regional or smaller hospitals in research, the more you'll find that there's an untapped potential for people who are enthusiastic, and also the more people at the front line will want to take the research findings on board in their day-to-day practice. And in the UK, perhaps more recently, there's been a big government austerity drive to try and reduce the budget deficits. And this this reduction in funding has resulted in less investment in infrastructure, less investment in training, and therefore a bit of a restriction or constriction in terms of the multi-center research work that's going on. So we need to find an alternative, and I put it to you that a very good alternative is crowdsourcing. You probably have come across crowdsourcing in a lot of different contexts, and crowdsourcing can be for any number of reasons. You can crowdsource for funding, which is what you'll find on Kickstarter, what you'll find on Indiegogo, where people with an idea or a new product come to you. You're a user, you look on your app, and you decide, oh, this is worth investing in, and I think it'll make a good product, and I want early access to this product. You could crowdsource for data acquisition. So if you need a lot of data, you need a lot of people. If you need a lot of people to collect the data, you need a lot of patients to collect data from. And thirdly is crowdsourcing for data analysis. And I'll just talk through a few of the examples that we can borrow from outside of the medical literature. So this is something that's very, very commonly done in the fields of astrophysics, in the fields of astronomy, and in the field of particle physics. Although I put up NASA as an example, there are now a lot of celestial bodies that have been identified through amateur astronomers just having an interest, having a hobby, having access to data that's been provided by these large telescope arrays. And people can just log on online in their spare time or lend a bit of their computing power to solve complicated questions where a single or a few scientists in a single institution will take years and years and years to solve. CERN, which is the European particle accelerator based out in, I think, Switzerland, make their data available after they've conducted their experiments to the wider physics community. And people bash their heads together and collaborate to share analytics of the data provided to come up with new and novel findings. In disaster relief, we find that there's a lack of good information on the ground about where infrastructure is placed. And after an earthquake is struck in a very rural part of the world, relief organizations need to be able to get relief to the people on the ground. This is an example from the 2010 Haiti earthquake. And on the left in the inset, you see the map of Port-au-Prince, which is the capital of Haiti, the day before the earthquake, and then on the right, 2 days after the earthquake struck. So basically what happened, organizations got together, they opened up OpenStreetMap, they got people around in coffee shops and had a good Wi-Fi connection, got people on their computers and laptops looking at satellite imagery, tracing around satellite images of the local area, and made maps so that it facilitated the dissemination of relief in the local areas where relief was needed. So how might this work in clinical research? This is an example from SnapOne, which was the study that preceded ours, preceded my PhD project, which is SnapTo. looking at patient outcome after surgery. Notice we've got 1,711 collaborators. The reason why we managed to get so many collaborators in that study is we offered them, on one hand, a sort of incentive that if you participate in our study, we will share any kudos, any sort of outputs from the study with you on the ground, the person who's helped us collect our data. And I think this is something that people have found very, very heartening. They felt involved in the study. And if you're involved in the study, you want to read the paper that you contributed data to. So this immediately creates some kind of impact. You're going to get at least 1,711 people looking at your paper. Number two, lots of people then go on and make use of this. They get an interest sparked, and it creates enthusiasm for further research in the future. So I think this was a very good example of how things might have worked in the UK. The surgical trainees in the UK have had a bit of a head start to us, and they've actually done multi-center studies which have gone international. And in some ways, the anesthesia and critical care community are lagging behind. But so we're chasing up. In the UK, we've established 21 research networks amongst trainees, and that's spread out throughout the country. The UK is quite a densely populated country. It's got 60 million people spread across a small island, probably the size of a single state in the United States. But it's still a reasonable geographical area that requires a bit of coordinating. So they've got independent organizations led by research-interested registrars. They get local trainees who may not necessarily have been exposed to research in the past, interested in research. And then there's an overseeing umbrella organization called RAFT, which is the Research and Audit Federation of Trainees. And they have multiple meetings throughout the year in their local regions, and then an annual meeting or biannual meeting in various parts of the country where they get all the research networks together to share the research work that they've conducted. Some of the projects that come out of these collaborations, you've got a mixture of things. There's a randomized controlled trial at the top. There's an observational study. And there's a retrospective audit of documentation in ICUs. But notice, each of these studies have involved more than one hospital across regions. Some have had up to 3,500 collaborators, and a lot of them have had patient data points in the thousands. So this is the study I'm more familiar with, because this is what I've spent the last 2 years doing, really. So I'll just give you a bit more insight into what we did. So SnapTo was a short, sharp, observational study into critical care referral after inpatient surgery. We did a coordinated 7-day recruitment simultaneously across the UK. So every site, all 245 hospitals, started recruiting at midnight, the 21st of March on a Tuesday, and finished recruitment on Monday evening, midnight, the 27th of March. So it wasn't a staggered intake of sites. Everybody started off the site on the same day and finished the site recruitment on the same day as well. We managed to recruit nearly, I think nearly all, probably about 96% of all inpatient surgical activity in the UK, at quite granular level. So we were at 170 data points on each patient undergoing surgery. We had 2,800 collaborators, 1,300 of which were trainees. And on top of that, we managed to get about 10,000 responses to surveys from clinicians about their perceptions towards critical care. So a lot of data. How did we manage to do this? This is just a picture of the sites that were involved. I'm sitting here in the office in the Royal College of Anaesthetists. That's down in London. At the top is our furthest site. That's Gilbert Baines Hospital in the Shetlands, which is in the outer islands of Scotland, 960 kilometers away. So we ended up needing to create some kind of infrastructure within the UK. Central to this is me sitting up there in the central project team in red. But there is a vertical axis that runs all the way through, relying very much on the research trainee networks that have been established. And alongside we've got existing structures within the Royal College of Anaesthetists communications channels, where every single member of the Royal College of Anaesthetists receives newsletters, receives emails, and so almost every single anaesthetist conducting surgery on that week would have known about our study. We've also got local consultant involvement, so the QARC and PIs, which is here. QARC stands for Quality Audit Research Coordinators. Every hospital in the UK has a single point of contact with the Royal College of Anaesthetists for the purpose of research, audit, or quality improvement. So these people provide local mentorship to the trainees about study delivery. We've also leveraged the NIHR, which is the National Institute of Health Research Clinical Research Network. So they've got a network of clinical research nurses, funding and infrastructure that go into hospitals to support the delivery of research. And we use multimodal communications. Here are some of the stuff that we use. We use loads of different tools. We used Eventbrite. I'm not sure whether Eventbrite worked in Asia. It's essentially an event managing system. You can go online, you can look for events, you can put your events up on a schedule, you can give people access to tickets. So we use that to coordinate webinars and online live stream events so that we can tell a large number of people, like in a lecture theater like this. I had a webcam, I was sat in front of a computer, I was explaining the study, I was walking people through the protocol, walking people through the CRFs, walking through the web tool where the data gets entered on. We needed to coordinate documents, so we used Teamwork, which is a project management tool. There are loads of these out there. Version control became an issue, because if you have any new version of the protocol, you need to disseminate it quickly. You need everyone to have a common access point for the right document at the right time. We use MailChimp to disseminate information throughout the study, before, during, and after, on every single day. And we use all these social media communication tools to spread the word about what we're doing, so that everybody takes on information in a different way. Some people are visual, some people are literal, some people are auditory. So we try to saturate every single information point that we could get. We use conventional media. So this was the newsletter that Royal College of Anaesthetists disseminates out on every 2-month basis. We wrote editorial pieces to try and explain the rationale behind the study so that everybody understood. We want to try and get people on the ground sort of interested in the study for reasons that might directly influence their care. So we explained why the study was needed. We explained how it might affect their care, because we think that the data that comes out from our study might affect policy in the future. The UK has very, very few intensive care beds, and we think that the data will inform the future workforce planning and infrastructure planning in the country. And this is the net result. These are pictures taken on different days of the study across different parts of the UK. We used Twitter. We asked sites to submit pictures of them actively taking part in the study. And then we fed it back to them. So very, very dynamic feedback of the stuff that they were sending in to us. Because when you participate in a study, you might submit data and not hear anything about the data until 2 or 3 years later. So we felt that that wasn't immediate enough for participants and disincentivizes people from taking part. So what we did, although we weren't able to feed back the data back to them, we could at least feed back the enthusiasm that they were showing us. And this creates even more enthusiasm for more activity. Every day, I took a series of 2 or 3 of these pictures and used MailChimp mail-outs to every single collaborator, alongside a little newsletter within the MailChimp email, with blurbs about journal articles which might be pertinent to the rationale behind the study. We leverage other incentives. So as trainees, we have a curriculum that we have to fulfill before we can be endorsed by the Royal College of Anaesthetists as fully fit to practice and as independent anaesthetists or intensivists. So we mapped all the curricular requirements to the sort of learning objectives that they would fulfill if they participated in our study. and we issued certificates to everyone. We sent letters out to hospital CEOs to let hospital management know that there are people within your institution taking part in this national study, which is of importance. And then, importantly, we allowed local access to data. So whilst the accumulated data centrally of all the sites in the UK will be analyzed by myself and a study team, local data we gave back to the people who gave those data points to us. The reason is we thought that this will be a good starting point for them to conduct local projects, local quality improvement, local audits. Because some of the outcomes data that we collected are things like post-operative morbidity. So we thought these will be good starting points for them to then introduce changes in their local environment, and then if they wanted, they can use our data tool to collect any further data they wanted. And I mentioned already collaboration, inclusion on manuscript outputs. So there are some pros and cons of crowdsourcing. You get a lot of significant enthusiasm from people participating, and this shines through, and you create a lot of future goodwill to participate in future studies. It increases the capacity for study delivery within your country. But there are some cons. I think not everybody's fully convinced of this. Not everybody has buy-in that the research data quality is of sufficient quality. But I hope to show in the future that once we go through validation processes of our data, that actually the data you get is of very high quality, because you get so much enthusiasm, people want to do things right. Future developments within the UK, we've got lots happening. There's the perioperative clinical trials network that's happening, that is an organization set up to conduct randomized control trials. We have skills training that's being provided from the college, teaching people principles of data science. I'm involved with teaching R programming to clinicians who may never have been exposed to this in the past. And we're trying to introduce protected research time in training schemes so that people get a bit more extra time within their day to actually conduct research. So in summary, I think this is an untapped potential that people definitely need to try and look on a bit more. It requires coordination, establish infrastructure in your countries, and this is a great way forward. And thank you very much to organizers for inviting me to speak. And it's been a wonderful few days. Thank you very much.